Hello everyone, welcome to our webinar. I, Dr. Shulagna Datta, welcome every one of you on behalf of Faculty of Dentistry to our this webinar entitled Conservative Neck Dissection. Our speaker is Dato Dr. Wan Mahathir Mustafa. So Dato Professor Dr. Wan Mahasir Mustafa is a professor in oral surgeon in Massa University. He was the senior consultant oral surgeon at Hospital Kuala Lumpur prior to joining Massa University. After graduating from the University of Melbourne, he went on to obtain his fellowship from the Royal College of Physicians and Surgeons of Glasgow in 1982. Upon his return to Malaysia, he was appointed consultant in 1984 and rose to the position of senior consultant and head of oral and maxillofacial surgery services, Mohe, Malaysia, a post that he held from 2000 to 2013. Datu Professor Dr. Wan was principal investigator and research on facial trauma in Ministry of Health Hospitals Malaysia and has participated in research on stem cells and oral cancer and pre-cancer in Malaysia. He is currently honorary editor of the Malaysian Journal of Oral Maxillofacial Surgery as well and was the editor of the Coffee Table Book, A Special Calling, which traces the early history of oral and maxillofacial surgery in Malaysia and Hospital Kuala Lumpur as well. He has also co-authored a handbook, Oral and Maxillofacial Surgery Posting, Manual for Junior Dental Officers. Dato One has numerous honors and awards in his credits, the most prestigious being the Colombo Plan Scholarship Award for undergraduate dental studies, leading to a Bachelor of Dental Science at the University of Melbourne, Australia. Public Services Scholarship Award he has obtained for postgraduate studies, leading to a fellowship in dental surgery from the Royal College of Physicians and Surgeons of Glasgow. Fellow of International Association Oral and Maxillofacial Surgeons, Dato Panglima Sirajuddaulah Jamalulail DPSJ Award it's called. He has received that in 2012. He has also published three books, book chapters, as well as several manuscripts in peer-reviewed journal. We are very honored to have Professor Tato Dr. Wan Mahasir with us today to talk on a very important issue. We welcome Dato to the podium. The stage is yours, Dato.
Thank you very much, Dr. Sulagna, for your introduction. Good morning, everyone. Today we are having another webinar by the Faculty of Dentistry at Massa University. This time it is the Department of Oral and Maxillofacial Surgery presenting, and the topic for today is conservative neck dissection in oral cancer patients. This is something which I've presented before in China and in Indonesia, but we've not yet presented this here in Malaysia. It's a view of Kuala Lumpur. For those of you who are not familiar with Kuala Lumpur, the Twin Towers were at one time the tallest buildings in the world, and they retained the title of tallest Twin Towers in the world for a number of years till recently. For my presentation, I will begin by the introduction and history of the neck dissection. We will talk a little bit about the division of lymph nodes by level and the risk of lymph node metastasis and mortality. And then we will just have a look at the research we did at Hospital Kuala Lumpur in terms of conservative neck dissection, and that will be followed by a discussion, conclusions, and at the end of the presentation, there is a list of references for those of you who wish to do some further reading. Introduction. The surgical management of the neck plays a very important role in the management of cancer of the oral cavity. And in 1980, a chap called Kosher proposed removing nodal metastases for the treatment of oral cancer. In 1906, Cryle emphasized the block dissection of the regional lymph nodes was necessary for effective treatment of oral malignancy. Here's the man. This block dissection or radical neck dissection that was recommended involves the removal of lymph nodes in the level of 1 to 5 in the neck, and also the sternocleidomastoid muscle, accessory nerves, and the internal jugular vein, as shown in this diagram here. The nodes that are removed are the level 1, 2, 3, 4, and 5 nodes, which are the submental and submandibular lymph nodes, upper jugular, middle jugular, lower jugular, and the posterior triangle lymph nodes of the neck. Although radical neck dissection has proven to be a reliable method of treating patients with head and neck cancer, it is associated with significant morbidity, and Hayes-Martin believed that routine prophylactic neck dissection was probably unnecessary. It was too radical an approach for the management of oral cancer. The morbidity associated with this gave way to modifications of the radical neck dissection to try and reduce the side effects, at the same time maintain oncological safety for the procedure. Modifications of the radical neck dissection was first described by a chap called Suarez, who's Argentinian, in 1963, in which a conservative procedure preserving structures such as the IJV, sternocleidomastoid, and the accessory nerves was done to reduce the morbidity of the operation. So can this variation of neck dissection reduce morbidity yet maintain oncological safety in Malaysian patients? Is there evidence to support this change in paradigm in managing our patients who undergo surgery for oral cancer? So we decided to do this research at Hospital Kuala Lumpur. That is the research on conservative neck dissection in oral cancer patients, a 5-year retrospective study in Malaysia. This is where the study was done at Hospital Kuala Lumpur. And the objective was to describe the impact of conservative neck dissection surgery on the degree of morbidity, with particular reference to the recurrence and nodal metastasis. Overall median survival and survival curves according to site staging and radiotherapy were also assessed. Materials and method. Patients who underwent major ablative surgery of the head and neck region with neck dissection were identified and clinical records were assessed. The inclusion criteria were stage 1 to stage 4 oral and oropharyngeal malignancies necessitating resection at the institution with or without radiotherapy from the year 2004 to 2009. All individuals had pre-operative assessment prior to surgery, and the post-operative assessment period ranged from 1 to 5 years. Survival distributions were analyzed using Kaplan-Meier curves. The results are as shown below. 87 patients, 38% males, 62% females were included in the study, and the age range was from 21 to 85 years. Some 78% of patients underwent neck dissections, while 63% had surgery and radiotherapy. The age distribution of patients are as shown in this chart. It is patients in the 51 to 60 years old age group that were the most presented the most. In terms of T-staging, the majority of our patients presented late. 50% were T4 lesions. Smaller numbers of T2, T1, and T3 lesions were also found in the study. Nodal recurrence was detected in 5.7%, whilst 20.5% had primary site recurrence within the study period. The Kaplan-Meier survival analysis revealed that median survival time was 57 months, as you can see in the diagram below. The 1 year overall survival rate was 72.7%, and 3 year overall survival rate dropped to 61.5%, as shown in the survival curve here. The overall survival curve is shown in here again, slightly magnified so that you can see better. And when you look at the survival curve by staging, it is the ones which lowest the stagings T1, T2 that survive longest. In terms of ethnicity, there is a difference between Malay and Chinese patients, and the Chinese tended to survive better than Malay patients. As you can see from the survival curve here, the green is for the Chinese and the blue is for Malay patients. The recurrence-free survival analysis revealed that 25% of patients have reached the event of recurrence at 46 months. 1 year recurrence survival rate was 85.2%, and the 3 year survival rate was 76.1%. By site, some sites lead to better recurrence-free survival, as you can see from the graph, and also this table. This is the patients with alveolar squamous cell carcinoma that survived better than the rest. Coming to the discussion, surgical management of the neck, as mentioned earlier, plays an important role in the treatment of cancer of the oral cavity. And a frequent cause of treatment failure is regional recurrence in the neck. So the surgeons in the past has advocated radical neck dissection to deal with this problem. But they discovered the classic radical neck dissection, which involves the removal of lymph nodes at level 1 to 5 in the neck, the sternocleidomastoid muscle, accessory nerve, and also the internal jugular vein, involves significant morbidity. They also found radical surgery is not associated with improved prognosis. So surgeons over the past several decades have been on the lookout for the optimum way to manage the neck in oral malignancy. The unacceptable morbidity gave way to supraomohyoid neck dissection, and also the modifications of a radical neck dissection, which was first described by Suarez, which is a conservative procedure preserving the structures such as the IJV, sternocleidomastoid muscle, and the accessory nerves in the interest of reducing morbidity. Just to show you what the supraomohyoid neck dissection is, it is a procedure that involves the removal of lymph nodes at level 1, level 2, and level 3. The modified radical neck dissection is divided into 3 types. For the type 1, it's only the spinal accessory nerve that's preserved. For the type 2 modified radical neck dissection, structures that are preserved are the spinal accessory nerve and the internal jugular vein. As you can see in this surgery curve picture, the accessory nerve is shown with the arrow there, and the internal jugular vein is the structure running vertically from the mandible, lower border of the mandible, to the upper border of the clavicle. In modified radical neck dissection type 3, all 3 structures, spinal accessory nerve, internal jugular vein, and the sternocleidomastoid, are preserved. So neck dissection is a time-honored procedure to treat metastatic carcinoma to the neck. Cryle emphasized the block dissection of the regional lymph nodes was necessary for effective treatment of oral malignancy. As mentioned earlier, this involved the removal of not only the lymph nodes but structures, sternocleidomastoid, accessory nerve, and internal jugular vein. When you do this, Of course, there is the morbidity associated with it, but it was the dominant surgical procedure for removing suspected or obvious metastasis to the cervical lymph nodes for much of the 20th century. What is the morbidity associated with the rectal neck dissection? Here's an example. This patient, this lady, has had radical neck dissection on the right side of the neck. You can clearly see the deformity. On the left side, there's no surgery done. You can see the deformity, cosmetic deformity. You can see also the shoulder, which is a cropped shoulder. So it's not a very good thing to have. When you do a bilateral neck dissection for the patient, you can see the difference between the various procedures. The this man, this gentleman, has had on the right side the radical neck dissection, the classic radical neck dissection. You see the drooping shoulder, the loss of nut volume, the shoulder pain and stiffness is experienced with this man as well. When you look at the when you look at the other side, the left side, this difference can be seen, although it's not as obvious as in the previous patient, the lady. The side that underwent selective neck dissection had much less deformity. You do not see the loss of neck volume that you see on the right side, and you don't see the drooping shoulder as well. So this morbidity gave way to the modifications of the radical neck dissection. And the rationale for this was to reduce post-surgical shoulder pain and shoulder dysfunction, to improve also the cosmetic outcome, to reduce the likelihood of bilateral IJV resection with contralateral neck involvement, which happens from time to time. And when you do this, you're able to preserve neck structures such as sternocleidomastoid muscle, which enables you to use local flaps for reconstruction of, for example, the tongue. Preservation of IJV and its tributaries also facilitates reconstruction using free flaps. Let's look at some examples. This is a case of 60 years old gentleman presenting to the oral maxillofacial surgery department with a complaint of non-healing ulcer on the left ventral surface of the tongue. The size of the lesion was about 2 times 1 cm, which on biopsy turns out to be squamous cell carcinoma of the tongue. Tongue movement, however, was not restricted. And this was published in the Malaysian Journal of Maxillofacial Surgery. And the flap that was selected for reconstructing the tongue in this case was the sternocleidomastoid flap, which is a type 2 flap according to the classification by Mattis and Nahai. The flap, the skin petal is outlined prior to surgery, at the start of surgery. It's 6 by about 4 centimeters size. And when dissecting the neck, care must be taken to try and preserve the vessel that supplies the middle third of sternocleidomastoid muscle. This is to enable you to keep the skin petal as much as possible. This diagram shows you the sternomastoid branch of the superior thyroid artery, which runs backward across the carotid artery to supply the middle third of the sternocleidomastoid muscle. This is section, very clean and well done, showing you the branch to the sternocleidomastoid muscle. The defect is shown here after the tumor has been removed. Of course, you do your what you call frozen sections to be sure the margins are clear. And when you're sure the margins are clear, according to frozen section, that is, you are able to tunnel the flap into the defect area and suture. The closure is watertight so that there is no leakage of fluids into the neck. Despite preserving the sternocleidomastoid branch from the superior thyroid artery, there is partial skin loss experienced by the surgeon, by this patient, sorry. And so, but at 11 months, you see that the skin has epithelialized over the area which had previously necrosed. And later, at 2 years post-operatively, you see this symmetrical tongue volume, which was restored to give the patient a good function and rehabilitation. And when you look at the series using stereoclear myocutaneous flap for reconstruction, the flap is very successful when you use for oral cavity reconstruction. The success rate is 100%, although there is a little bit of necrosis in 3 patients, as shown in the study by Charles et al. In 1987. Preservation of the IJV also allows you to use it or the tributaries of the vein as a recipient site for vessels in the event you choose to do microsurgery for reconstructing the oral defect. You can see there the arterial anastomosis, which is not very visible because it's using very, very small sutures, but you can see very clearly the anastomosis of the vein, which is done by using a coupling device. Here is a picture of the radial forearm free flap inside you. It's quite a big flap, 8 by 15 centimeters. And this procedure would not be possible if you had sacrificed the internal jugular vein in a classic radical neck dissection. You would have to source the vein from another place, another site. So the performance of neck surgery, even when neck is clinically negative, has altered the incidence of failure from recurrent neck disease. The neck failure rate of 5.7% recorded in this study is low and may be attributed to the inclusion of level 4 and oftentimes level 5 in the performance of surgery for the neck. This approach is partly based on the findings of Krian et al., who found an incidence of about 10% occult metastasis when they included level 4 in the neck dissection, the neck resection. The survival rate in our series was comparable with other series at about 50% at 5 years. This is despite the fact that many of our patients, in fact, presented with T4 lesions. Yes, you can see that half of our patients, in fact, had T4 lesions, and we still managed to get a survival rate of about 50% at 5 years. There is a close relationship with staging in terms of survival. The T1 and T2 patients tended to survive longer. In the study, however, we found a significant difference in survival between the Chinese and the Malay population. We attribute this to better oral healthcare awareness, leading to the Chinese presenting earlier for treatment, and also to accessibility factors. There is the possibility that the Malay are more likely to seek traditional treatment as the first option. So for the present and also for the future, there are still some questions which remain either unanswered or partially answered. Is level 5 neck dissection always needed? Can level 2 B nodes be preserved and yet maintain oncological safety? Is it necessary to remove the submandibular gland in a neck dissection? These are questions which remain to be fully and satisfactorily answered, and it is probably a topic for future research, perhaps by the same place, this hospital, Kuala Lumpur, which does many neck dissections. So in conclusion, conservative neck dissection is effective in conjunction with post-operative radiotherapy for control of neck metastasis. We were able to maintain oncological safety in our patients who underwent this type of neck dissection. In our series, Ethnicity appears to influence the survival of patients, but a prospective trial is required to validate this. Conservative neck dissection preserves structures which can be used or facilitate the reconstructions of defects caused by tumor excision. These are my references. The first one is actually the study that we did, and number six is a case report by Azlin Jitong and Professor Chang Chingping in the Malaysian Journal of Oral and Maxillofacial Surgery. And if you want to look at Mattis and Nahai, the classification of vascular anatomy is in the Plastic and Reconstructive Surgery 1981. Um, Thank you also to Dr. Satish and Jolene for the data collection and literature review. Thank you to Ms. Tasha Hilda, Prema Subramanian, and Mr. Adam Bujang for statistical help, and of course, Dr. Sazmin, Professor Zhang, and Yi Tiong for slides on the stenocardiomyocyte flap. Thank you for your attention.
Thank you very much, Tato, for your valuable time. And we are really honored to have such a big name in oral surgeon to deliver webinar for our faculty. So we will look forward to future webinars from you, Dato, and hope everyone have enjoyed. We thank all the audience for joining today with us in this webinar, and thank you very much. Please view all our webinars that is being conducted by Faculty of Dentistry, Masa University. We don't find any questions here. Maybe everyone has got good insights, and the webinar has also inspired the potential students to dream big, to opt for oral surgeon, and in this field, I hope you have got enough knowledge. Thank you very much, Tato, once again. Everyone, stay fit, stay well. Bye bye.